Introduce Dr. Jack Sobel, who has too many titles and too big a CV to cover in the time that I have. Dr. Sobel is currently an emeritus dean of Wayne State University. He was chairman of medicine during a really pivotal time here at Wayne State in 2014. And before that, for many, many years, was the chief of ID and built the ID division here in Detroit at Wayne State into really a worldwide renowned division. Dr. Sobel is a world expert in candidal infections and fungal infections and bacterial vaginosis, vaginitis, and other sexually transmitted diseases. He also is a master clinician. He did an internship in surgery in South Africa, so he's old school, diverse, and wears many hats. Above all, I think Dr. Sobel is a true mentor. He's been a critical force and guiding light in my career. And I owe a lot to him. And it's my distinct pleasure to turn things over to Jack now, who's going to talk to us about current challenges and advancements in treatment of vulvovaginal candidiasis.
Okay, so I changed the topic from what I promised, because I really did want to talk to you about some of the new antifungals that have recently become available and will be, and you as in the ID world, these drugs will sort of, when new antifungals become available, the easiest way for the pharmaceutical companies to study these new drugs is to go to superficial infections. They can either go to oral candidiasis, for which there's not an awful lot around in this world, or they go to vaginal candidiasis, where there's a great deal available all over the world. So they study the drug in great detail at a superficial level, and eventually, after a couple of years, they start looking at these drugs in onychomycosis, and then they go a little deeper, and then they move to intravenous and to systemic infections, where they now convert the oral or topical agent into an intravenous agent. And that's really the pattern of developing very often antibiotics and certainly antifungal agents. So actually, at a mucosal level, we are way ahead of the general ID doctor. So that's the one reason I wanted to talk to you about these new drugs today and vulvovaginal candidiasis. On the other hand, vulvovaginal candidiasis is a real infectious disease, and we can learn a lot about infectious diseases and pathophysiology by studying a simple mucosal infection, which is not so simple. When one sees patients referred from all over the country with chronic and recurrent and vulvovaginal infections, etc. So this is the topic, and I'm going to just hit the down arrow. Okay. So vaginal candidiasis is really worldwide, and even the recurrent variety characterized by having at least 3 or 4 attacks per year. We talk about almost 150 million women. So it's a very common entity. There's no ID doctor in private practice today who's not going to see women with recurrent candida vaginitis. And you're not well trained in terms of understanding the appropriate management. So it's just very common with a high personal price that women pay, as well as with the economic consequences, are also significant. So most of the vaginal infections in the United States and Europe are caused by Candida albicans. Up to 10%, or 5 to 7% Candida glabrata, which is a very different yeast species, a very different species. And although in some countries, for reasons we're not quite sure, certainly West Africa, Brazil, we see a lot of non-albicans Candida species. But if you were looking at the epidemiology of candidemia, you will see that whereas 90% of the candidemias used to be C. albicans worldwide, this has dropped to below 50%. This has not happened with vaginal candidiasis. It's still dominantly a disease caused by Candida albicans. So why are species so different? Because they vary in their virulence, their ability to express virulence factors, most importantly, their ability to germinate and to form pseudohyphae and hyphae is critical. A recently recognized very critical virulence factor is Candidiasis, which is possible for causing apoptosis and inflammatory changes in the vaginal mucosa. The clinical spectrum varies. Candida albicans being the most common causes both an inflammation of the vagina and the vulva. So women complain of vulva manifestations, whereas Candida glabrata, much less virulent, very resistant, but much less virulent, does not form hyphae, and it tends to cause vaginal symptomatology, irritation, soreness, but not inflammation. They vary, the species vary dramatically with regard to their susceptibility and their persistence after antifungal therapy. So I wanted to spend a little time about diagnosis. Most practitioners diagnose Candida vulvovaginitis based on symptoms and signs without doing any laboratory testing. And I can tell you, firstly, self-diagnosis by women, very unreliable, very unreliable. Most women who think they have a yeast infection go to buy an over-the-counter monostat or everything else, really don't have Candida vaginitis. More than 50% of the women buying monostat at this moment in time don't need the monostat. They have another reason and an explanation for symptoms that are very non-specific. The good clinicians, unfortunately, rely on the measurement of the vaginal pH, which is normal in Candida vaginitis. They rely on traditional point-of-care microscopy and do cultures, and you get a result back in 48 hours. And they are very reliable. Well, nothing happens today that is not translated into next-generation sequencing and molecular methodologies. And these various, starting with DNA probes, but moving to PCR, the sensitivity goes up very modestly. But it takes, you don't get a point-of-care, you don't get a culture back. You get a culture back in 48 hours, you don't, but the point of care tests will tell you what's going on within immediately. So there's no replacement for point of care training and point of care competence. And most practitioners are unable to use a microscope today. So we don't think the PCR is the new gold standard. We still continue to believe that cultures, which are about 5% less sensitive, or should remain the gold standard. So let's talk about the pathogenesis. It starts off with colonization of the vagina, almost invariably of gastrointestinal source, and estrogen is critical with regard to the adherence of the epithelial cells. Multiple factors are involved in the interaction between the various receptors on the epithelial cells and different receptor binding lectins and others on the cell wall and cell membrane of the yeast. But asymptomatic colonization is normal. The norm of this condition is asymptomatic colonization. And you could walk out into the streets and pick up 100 healthy asymptomatic women, and you're going to find that 15 to 20% of these women at this moment in time in a point prevalence study are culture positive with colonization. If you follow up, do a longitudinal study, which we originally did about 20 years ago, and you follow up women for years, you find that intermittent colonization in some women, but most of these people are asymptomatic. In other words, there's no inflammatory response, and that's not a chance phenomenon. The lower genital tract is immunologically primed not to react to Candida and to facilitate and to allow colonization without massive overgrowth. This process is called vaginal tolerance. So there's a natural immunologic tolerance whereby a woman will tolerate even large numbers of yeast in the vagina without developing symptoms or inflammation. The entire lower genital tract is, from an evolutionary point of view, has developed so as to tolerate foreign proteins, semen, sperm. So this tolerance is a downplaying of the immune response, and that's normal. And so having the end point of therapy of treatment of a woman who has acute or recurrent Candida vaginitis is not to eradicate Candida permanently, because you never eradicate Candida permanently, because colonization and recolonization or reinfection is going to happen. Your aim of therapy is to control symptoms. This is a very different concept in infectious diseases, where this is not group A strep. By the way, you never eradicate group B strep from the vagina anyway. You give group B strep antibiotic coverage during vaginal deliveries to prevent group B strep sepsis in the newborn. There is no group B streptococcal vaginal infection. And you never eradicate group B strep. That's why you have to screen them with each pregnancy. But you will eliminate group A strep, which is a totally different organism. Anyway, once the patient becomes colonized, a second process occurs, and that's the trigger. A trigger arises, which allows overgrowth of the yeast, and it overwhelms these down-regulating immune natural mechanisms, and therefore they eventually induce an inflammatory response once they've evaded the down-regulating cytokine production, and inflammation occurs. And we used to say that infection is really never, there's no invasion of the vaginal mucosa. And that's because they never did vaginal biopsies. Actually, invasion does occur. This is not an infection just of secretions, this is invasion of the mucosa. What is different is that women with recurrent disease are more prone to colonization, and they're more prone to not tolerating yeast in the vagina. They simply don't tolerate recolonization. And that's because they've got a maladjusted immune system. That is what and we'll talk a little bit more about it now. The fundamental reason why women get yeast infections is that they genetically are predisposed, but it's not a monogene. It's not like hemophilia. It's a polymorphic phenomenon, and there probably are 8 or 9 genes that have been identified that set up patient X to be prone to yeast infections. And this patient goes through life, she never becomes colonized. They go through antibiotics courses, they go through life, they have all the triggers in the world, they never develop a yeast infection. And this is all a function. So whether or not you're going to get any woman gets a vaginal yeast infection is really based on the luck of the draw. Did she get the right genes? And once she has the genes, you can't cure those genes. What you can do in controlling a lifetime susceptibility is you control the trigger mechanisms and you control the symptoms. You're not ever going to eradicate or change the gene phenomenon. Okay, so what are these triggers? We divide these triggers into host triggers, such as uncontrolled diabetes, systemic steroids or topical steroids. The commonest trigger is antibiotics, especially with an inappropriate antibiotic therapy, whether it's topical antibiotics or systemic antibiotics. Hormone replacement therapy, estrogens is a very important trigger. And so women, this is the single most important trigger in postmenopausal women. HIV is a minor risk factor, and although I put it first, sexual activity is another risk factor or trigger. It's not that it's, and we'll talk about a little bit more about that in a second. So some of the triggers facilitate colonization, and some of the triggers will actually facilitate this transformation from colonization to an inflammatory state. And these are the common ones I mentioned, antibiotics, and there's no antibiotic that is free of this risk factor. The tetracyclines, whether the doxycycline, which are given to women for acne, for example, for chlamydia infections, commonest cause of yeast infections. Coexistent vaginitis, this is one of the most rarely studied and something that we're doing research on today. Women with bacterial vaginosis invariably get Candida vaginitis. And we thought all the years this is because we're giving them antibiotics for the bacterial vaginosis. Sure, that is a reason. But we've now recognized that even without antibiotics, the changes in the immunologic milieu of bacterial vaginosis facilitate Candida vaginitis in its own right. And that's what we're currently studying. Sexual activity can occasionally be a risk factor. Most of the time, it's not a factor. Uncontrolled diabetes, immunosuppression, steroids, and so on. Okay. So the genetic predisposition I'd like to spend 2 minutes talking about. We've known that anecdotally, there were always patients who reported a family history. The next phase is that experimentally, immunologists found that they could come up with inbred mouse strains and outbred strains that were more prone to vaginal yeast infections. This was in my studies. We knew from epidemiologic studies that we did starting off here 25 years ago, that there's no question that African-American women are more prone to vaginal Candida vaginitis, and this is not well studied or investigated. We also established that the Lewis blood groups were a marker of who was at risk of getting a Candida vaginitis. But the real focus that pointed to the role of genes was when immunologists and infectious disease doctors started studying chronic mucocutaneous candidiasis, a terrible condition which is very strongly found in families where they develop oral candidiasis, esophageal candidiasis, vaginal candidiasis, onychomycosis. They don't develop systemic candidiasis, but because systemic candidiasis is dependent on white cells. You don't have white cells, you get candidemia, you get disseminated infection. And the different families of these chronic mucocutaneous candidiasis, one of them is an abnormality of the COD9 gene, which affects one of the receptors for Candida, the dectin Candida, the STAT1 genes. And so there are at least half a dozen different forms of genetic disorders that result in vaginal candidiasis. But most women, bearing in mind that we're talking about 150 million women with recurrent candidiasis worldwide, if you screen them for these 6 or 7 genetic factors, they don't have them. So they clearly do not have these dominant genes, which results in just a lifetime severe infection. It's a much more subtle polygenic causation. And these are these tend to be SNPs, and one of the important genetic factors is a mannose binding lectin with polymorphism, which the MBL acts as an opsinin, and most genes cause, these polygenes cause Candida vaginitis by doing one of 2 things or both. They facilitate colonization. They massively enhance colonization. You can treat a patient who's got recurrent Candida vaginitis. You have them on daily fluconazole for a couple of weeks. They become culture negative. You stop the fluconazole. Within a week, they become culture positive again. They become recolonization, and we can talk about that in a minute. The second mechanism whereby genes cause Candida vaginitis is by influencing the inflammatory response in the inflammasome in the epithelial cells, the vaginal epithelial cells, and determining the threshold for being activated and their response. Women with recurrent Candida vaginitis are more likely to become colonized, but when they get an infection, when they become colonized, they can't tolerate the Candida. So they immediately switch on the inflammatory response, and they get a hyper-reactive allergic reaction or a reactive reaction, and they develop symptoms. And therefore, when we treat these patients with recurrent disease, we try to prevent colonization, and we try to modulate and to mitigate the inflammatory response. We can't change the genes. So I'm just going, this is exactly what I've said. So what about the vaginal microbiome? Remember, the 3 components to this whole process for any infection. It's the host, the epithelial cells, and the underlying T cell functions. It's the pathogen, the organism, and then of course there's the vaginal microbiome. And you can't survive anywhere in this country today in any academic program without studying microbiomes. So we have been studying microbiomes, firstly with culture methods for 25 years, and we've never shown any difference. We would see women with acute attacks. We would see women, just who have the susceptibility. We could never document by using traditional culture methods. When molecular methods and next generation sequencing came, the first many papers showed no differences. More recently, every now and then, a paper appears where they say, if you look at acute women who have acute disease or possibly recurrent disease, you tend to find some changes, not in the subtle lactobacillus species. And the one organism that tends to appear is not Lactobacillus crispatus or Jensenii that you may be familiar with. It's Lactobacillus iners, and Lactobacillus iners is very interesting. It doesn't produce lactic acid or hydrogen peroxide, so it's not a very protective Lactobacillus species. But whether this contributes to the susceptibility to the infections as a microbiome factor is really unknown and is being studied. So as you probably know, that in bacterial infections, they discovered a biofilm. And a biofilm is absolutely crucial to the recurrence of recurrent bacterial infections, because once an organism, the pathogen gets involved in the biofilm being attached to the epithelial cells and surrounded by a polysaccharide matrix, it becomes protected from antimicrobials in the biofilm. Organisms in biofilms undergo genetic changes and they become more resistant. And there's a lot of transcriptional activity occurs, turning on the virulence of these organisms, as opposed to organisms that stay in the lumen, which we call the planktonic organisms. So, for example, this is a normal, we've been trying to demonstrate a biofilm in a normal biopsy of a healthy woman. There's no biofilm. This is the biofilm that you see in bacterial vaginosis with and it's usually Gardnerella. It's actually polymicrobial, but we're not going to be talking about bacterial vaginosis today. So far, nobody has been able to show a biofilm in Candida vaginitis. And when we started doing biopsies looking, what did we find? We found that the organisms, these hyphae, look at these hyphae, are actually invading, not deep, because you don't get an invasive infection where you're getting candidemia. You never get candidemia. You never get a circulating immune marker or test of activity. But it's no longer, Candida vaginitis is no longer just an infection of the lumen, it's an infection of the superficial mucosa as well. And this was just not known and not widely recognized. And it's very important because, the short course therapy rapidly eradicates organisms in the lumen. But to get the organisms that are several layers deep, you need to prolong therapy. So duration of therapy is crucial, something that is not appreciated in the management of these infections. So we invest, I'm going to take you switch now to treatment, because I want to get to these new drugs. So if you look at this table, this figure, you've got here a patient who's got signs and symptoms of Candida vaginitis. And this is a culture, she's culture positive. And if you give traditional antifungal therapy for a week, after a couple of days, the symptoms go away. Within a week, the symptoms are gone. In order to, what these patients is problematic in these patients, that they become recolonized. They're going to become yellow again. You're going to see recol pop up. So you've got to prevent recolonization. And that's what we invented 25 years ago. We started using daily ketoconazole, and then we switched to weekly fluconazole. Beforehand, I would have had lots of errors with the daily ketoconazole. And in the first study, that we showed with fluconazole, we showed that if you gave fluconazole for 6 months, you can see the symptomatic attacks occurred in less than 10% of the women. You could prevent infections with a greater than 90% efficiency giving fluconazole once a week for 6 months. This is the control group. You can see 50% of the women develop symptomatic infection, symptomatic disease within 6 months. But look what happens when you stop the therapy after 6 months. They rapidly had recurrence because they became recolonized again. and at a year, they were having attacks at the same rate as the control group. So what we learned is fluconazole maintenance therapy for 6 months is very effective in giving these women a normal life. They have a greater than 90% chance of having a totally normal, asymptomatic life, as much as we can do this as physicians. However, we were never curing them. The reason why we're not curing them is we're not curing the genes. They're going to become recolonized. But what you do when you give somebody 6 months and they are culture negative for 6 months and the vagina remains culture negative, you remove the antigenic stimulation. And women that have that have as part of their recurrent susceptibility have got a hyperimmune reaction to Candida because they no longer tolerate, they do not tolerate a tolerant situation. By keeping them culture negative for about 6 months, when you stop it, they don't relapse. They don't have a recurrence. They actually, you've got about a 20 to 25% chance of curing them. And that's all you can hope to accomplish with therapy. So there are multiple.
Can I ask a quick question about that study?
Yeah.
How often did you see fluconazole resistance, Candida glabrata, or any colonization or infection with azole resistant strains occur in that population?
Okay, so firstly, we didn't even see resistance, what we can't consider resistance. Resistance for Candida albicans in the bloodstream, almost unheard of. You can write up a case report tomorrow of candidemia. That's Candida auris. Candida auris and its resistance. Candida albicans in the bloodstream almost is never resistant. And the reason why is that the fluconazole exposure is almost minimal. They get candidemia, etc. But in the vagina, women are exposed to to fluconazole all the time. They can buy fluconazole, they get it over the counter. No, they don't get it over the counter. They're exposed to topicals. So resistance is common, and we're going to talk about it, but it was unheard of when these studies were done. We now recognize that giving a woman maintenance fluconazole induces fluconazole resistance in C. albicans, about 5 to 8% of the patients. So we've got a cohort of several hundred women with recurrent Candida vaginitis that we've had on fluconazole for years. We've seen resistance now in about 5 to 8% of the women, but in over 90% of the women never develop resistance. Glabrata is more common in women that have been exposed to fluconazole because glabrata is intrinsically, without exposure to fluconazole, more resistant, as you point out. Okay? So the multiple protocols that have reproduced the last figure I showed you, and the efficacy is greater than 90%, but we don't cure. We didn't know that. It took us 15 years to do two studies that we did here. And we actually were able to publish both studies. We followed women up, and we actually showed we were never curing these women. We were fooling ourselves. What are our long-term options? One of the options is you keep them on fluconazole. Unfortunately, fluconazole is safe. But Candida resistance, as you point out, is an issue. And about under 10%, but 5 to 8% of the women are going to develop fluconazole resistance. When women with Candida vaginitis develop Candida fluconazole resistance, their whole life, their lives change, because it tends to be a pan-azole resistance. So resistance occurs to ketoconazole, to itraconazole, and therefore it's a nightmare when women develop Candida albicans resistance. There was an attempt made at a vaccine. It wasn't particularly effective, and nobody's studying vaccines today. So, since you brought up the subject of resistance, here's the slide. Intrinsic fluconazole resistance in virtually all strains of Brucei half the strains of parapsilosis and about 60% of the strains of glabrata have intrinsic fluconazole resistance. And it is no question that this resistance is a function of exposure. Acquired fluconazole resistance is much less common. And we don't have new drugs. We're going to talk about the pipeline drugs that have just been introduced. This is all that is left because of the pan-class resistance. We use boric acid. And boric acid, as you well know, was discovered by Lister. That's 250 years ago. And it's still available. You can get, and if you want to know where you get boric acid from today, you get it on Amazon.com. You can get it at Target. You could also use nystatin, which is, as you know, derived from amphotericin. Flucytosine is very effective, but it's very expensive. You just can't get it. But I want to talk to you about these pipeline drugs. But a word about boric acid. Told us, Lister discovered it. It is useful. You could probably control 60%, 70% at best Candida glabrata. Very useful, however. It's what we go to when we first discover fluconazole resistance with albicans or non-albicans strains. It is given daily. It's very cheap. It's less than $1 a capsule. You can get it at, as I said, all over the place. We use a capsule of 600 milligrams of
Can you guys just make sure to mute your lines, please? Everyone make sure their lines are muted. Thank you.
So, and it's very, we've done lots of, there've been some lovely papers just produced recently showing that daily boric acid is very safe. It's well tolerated and it's not absorbed. You don't take boric acid by mouth. You give a patient boric acid by mouth, you go to jail. It's very toxic by mouth. And we've given patients, I've got several patients that have had boric acid daily for 5 years. The dose is 600 milligrams. There's never been a study comparing 600 with 500 or 400 or 300 milligrams. How did I choose 600 milligrams when I first started using boric acid? I knew I needed a capsule that would dissolve rapidly. So we found some gelatin capsules and we filled it. And then I turned around to the pharmacist and I said, how many milligrams did the capsule hold? He says, it holds 600 milligrams. I said, okay, that's the dose. So be it. That is the science. It was never a dose range study. And it's never changed. Candida glabrata is much lower virulence. In the bloodstream, not so. The candidemia has high virulence. It doesn't cause vulvar symptoms. It doesn't cause the extensive inflammatory changes, the erythema, the edema, the itching, and the rashes. But when you find it, you've got to establish causality. If somebody says, what's the core of being an infectious disease, doctor? What is the most important thing you learn in 2 years of study is you learn causality, you learn causation. That when you get an organism, whether it's from a wound, from an aspiration, from an abdominal abscess, you have to, you go through the process which you do unconsciously of deciding whether an organism is a pathogen or whether you're going to ignore it. Am I going to ignore the staph epidermidis? When can I not cover enterococcus, etc.? Not in Candida. I'm not talking about bacteremia. You establish causality. Candida glabrata is a very common colonizer. It's a rare pathogen. And patients are, and one of the commonest reasons why ID doctors are going to be sent patients, referred patients, is when a woman has symptoms and the gynecologist makes the mistake, it's probably their first time they've done this, they do a culture and they get back Candida glabrata and they tell the patient, oh, you've got this resistant yeast, let's just treat it. And you've got to establish causation because the chances are that the patient has another reason for the symptoms, and the Candida glabrata is what we call an innocent bystander. We never treat asymptomatic Candida glabrata. Why? Because it's so hard to get rid of. And you never want to start treatment for the patient in whom you build up their hopes of curing them if they're asymptomatic. Don't do that. So we start off with either boric acid, nystatin, And now we've got these two drugs, of which I'm going to talk about, ibrexafungerp and oteseconazole. After having had no new drugs in the pipeline for 2 decades, all of a sudden, there are 2 new antifungals. So the first is ibrexafungerp, and we're going to talk about it. It became available commercially as a drug called Remifem in August last year. It's a tritipenoid antifungal. It is not an azole. And what's interesting is that it's very similar to the echinocandins in that it's a glucan synthase inhibitor. It does not work like an azole. So it's very similar in its structure to caspofungin, but it's not different. It works literally the same way. Remember that caspofungin and all these drugs are only available intravenously. This is the first drug available topically or orally, and it'll soon be available intravenously. And you'll be doing studies, no doubt, on this drug. So this is how it works. It's a glucan synthase inhibitor, and it will actually inhibit the cell wall. It doesn't work on the ergosterol mechanism that azoles use. And it's actually not bad against Candida auris. It's one of the new drugs in the armamentarium against Candida auris. Just to mention that Candida auris has never caused Candida vaginitis. I'm sure this is something you want to remember. It's a broad spectrum. It is cidal, like echinocandins. It's active against many of the azole-resistant Candida species. And most important, ibrexafungerp works at a low pH. And that's because the vaginal pH, in contrast to the pH of blood, is not 7, and the pH is 4. And many of the drugs that do get into the vagina are affected by the pH. Amphotericin, for example, is very pH dependent, which is why we've always known amphotericin is never good for abscesses, or fungal abscesses. It's in the heart of the abscess here, the pH is high. It just doesn't work. You know, at the time of making this sort of slide, they said, no, it can be used, its half-life is 20 hours. They said it can be used in pregnancy. Well, the FDA didn't agree. So it's now did not get approval for use in pregnancy, which is took the heart and soul out of this new drug. So there have been several studies with these drugs for this ibrexafungerp in pregnancy. I'm sorry, in Candida vaginitis. And these were called the Vanish and the Dove studies. You know, when a new drug becomes available, a new antibiotic, the FDA has the option of deciding whether the phase 2 and phase 3 studies, the phase 2 studies, as you remember, are really tests of principle, proof of principle, proof of efficacy. The phase 3 studies are, you know, include an element of safety, toxicity, as well as efficacy. But for new drugs, once they've established safety, they don't require that any new drug be tested against an existing drug in that has already been approved or not approved. So the companies, the FDA is happy with them doing a study comparing it to placebo. And the companies rush to do placebo because it's easier to do a superiority study against placebo. And when you do it for a superiority study, you don't need as many patients in your phase 3 studies. Most of the time, you need fewer patients. So these are the studies against, in the Vanish studies, they gave a single dose of ibrexafungerp. It's a single dose therapy, but the dose is divided into a morning dose and an afternoon or evening dose. And they were able to show a test of cure. This is 1-day therapy. The test of cure was about 63%, which is comparable to all previous drugs. Comparable. And at follow-up, actually got a little better. In all the studies they did, it was always higher at day 25. This never happens with fluconazole. So what was attractive was it was probably comparable to fluconazole, and maybe it was they never did enough studies comparing it to fluconazole. But it looked like it actually may have a longer duration clinical effect. So this is a drug which is not a giant breakthrough, and its clinical cures, as I said, in the study. You're talking about 50, 50 to 60% with a culture eradication rates of about 50%. This is pretty much normal for these antifungal studies. I just wanted to go back to say, what is this new drug has been available for since August. It's expensive. And whenever companies, they've got to get back their investments, they've got boards, they've got investors, and the drug is very expensive. And they're competing against fluconazole, which is widely available, generic, and inexpensive. So the drug is to replace fluconazole has to be really superior. It's certainly valuable in people who are so wonderful a drug to use when you have fluconazole allergy. If you're allergic to fluconazole, you go straight to this drug. If you are fluconazole intolerant, you don't go to this drug. If you have toxicity of fluconazole, which is not common, by the way, you go to this drug. You take these three combined indications, it probably matches 5 to 10% of the patients with acute Candida vaginalis. The other 90%, if it's going to be used as opposed to fluconazole, which is much cheaper, is a little bit of a stretch, and that's unclear. And the drug has never been shown to be superior to fluconazole. So whether or not it's going to survive in the other 90% of patients who are not allergic, not intolerant, and no toxicity, well, in the patients, is there a growing resistance? Well, there is. There's about a 5 to 8% resistance rate of fluconazole, of C. albicans to fluconazole. This is another indication. So it's becoming a niche drug, probably useful for about 10 to 20% of patients, but expensive, and that's an issue. The other drug is a drug called oteseconazole, and it's an azole. It's a fungal CYP51 inhibitor with tremendous potency. It has unique avidity for fungal receptors, which are very similar to human receptors, but the actual attraction to the fungus compared to human. So it's much more potent against yeast than fluconazole, and really doesn't cause any of the toxicity that although uncommon, is associated. So you've got a more potent drug. So far, the reproductive toxicity study says it's not teratogenic, but the FDA has not yet agreed that it's going to be allowed to be used in pregnancy. It's because of its potency, it's active against azole-resistant strains, and it's active against non-albicans Candida. But what's remarkable about this drug, it's got a half-life in months, not weeks, not days, months. And the combination of potency and long half-life is taking women with, I'm going to show you the results. So for example, this was a dose range study. They wanted to know how long to give it and so on. And they compared it to placebo. And these are women with recurrent Candida vaginitis who, after getting an initial induction course of therapy to get a patient into remission, the placebo at 6 months, 50%, 32% had a culture verified reinfection. These are the infection rates. It's all below 5, below 10%. Dramatic decline. And if you go to a year, it stays the same.
How often is the oteseconazole given?
So I'll tell you, in this study, they gave it in, I'm going to give you those details right now. And the safety was remarkable. So the safety is great. So this is the first study called the Violet study. And they first did it and treated, these were women with recurrent Candida. These were your worst cases, recurrent Candida vaginitis. They gave them initially what they called an induction regimen, 150 milligrams day 1, day 4, day 7, to both arms. And then this group got placebo. And this patients, they gave them oteseconazole for a week daily. And then they gave them once a week for 3 months, total of 3 months. So it's 3 months. Remember, fluconazole we were giving for 6 months as a start. Here it's cut by half. And you can see that compared to the placebo, once more you're getting recurrence rates of 40+%, and here it's still below 7% in their two arms. Then the toxicity was no different from placebo. So the recurrence rates were 90% lower than fluconazole, both during the time they were taking the drug and when they stopped taking the drug. And this effect was extended for 6 months after they stopped the drug, which you didn't see with fluconazole. So then they did yet another study. It was called the ultraviolet study, in which they said, why are we giving these patients fluconazole as an induction? They said, let's give them oteseconazole. So they gave them oteseconazole 2 doses, day 1 and day 2, versus fluconazole 3 doses, and then put them onto placebo versus 11 weeks or 3 months. And they followed these patients up for up to a year. And once more, the recurrence rates are incredible, under 5.1% at 1 year. So at 1 year, only 5% of the patients were having recurrences. Under placebo, it would be 50 to 80%. This is the placebo in this study. It was only 42%. So so you could say the results are amazing. So the question is going to be, we've now followed many of the patients, because we did the studies in my clinic. We've shown that many of these women who are having recurrent Candida vaginitis with fluconazole susceptible organisms, we followed them for 2 years, and many of them remain attack-free at 2 years. That's totally different from what the picture was before. So the drug has not yet been released, and they're busy arguing and negotiating with the FDA, and this has been going on now for 6 months. So I wanted to talk, so what we talked about the new diagnostic tests are available. You can get from all the commercial companies, LabCorp, whatever you want to, any company, Cepha, and you can get molecular diagnosis. Not a big advance over traditional culture, but make a diagnosis. We talked about pathogenesis. I've spoken to you the 2 new antifungals, and perhaps we've discussed briefly the problem of resistance in Candida vaginitis. Still not a traditional infectious disease topic, but I think that all ID doctors should know about this important mucosal infection, because if you're going to be in practice, you're going to see women referred to you with this problem. So I'm happy to answer any questions.
Jack, I'll start off. When I know you see sort of a very specific, somewhat biased cohort by the time they come to you, but with referrals to ID, what would be typical symptoms, and would there usually be culture positivity at the time that they're sent to you, or what?
Yeah. Most of the referrals to ID doctors are when the doctors do cultures.
Vaginal culture.
Vaginal culture. Now that they're becoming more affay with molecular testing, they do a swab, whether they do the one swab or the new swab, they send it to LabCorp, they get back results. They get back all the bacteria, Atopobium, Gardnerella, Prevotella, and they get back all the Candida species. So now for the first time, the doctors are seeing the species. They don't know what Candida parapsilosis is. They don't know what Candida, they've never heard of Candida parapsilosis. So now the doctors are because of the availability of molecular testing, they're getting the results whether they wanted them or not. And they're not trained. Gynecologists are not trained in knowing species. So the first thing they do is they ship it off to an ID doctor. 1. 2, there is resistance. And the resistance is becoming an issue. And the reason why we don't see it with invasive Candida infections is that they don't have fluconazole exposure. Women are getting fluconazole exposure. That was Draw's contribution, exposure.
Any questions from the group here?
Yeah, I have a question. which sort of relates to some of that about diagnosis, that if they have molecular diagnostics and most people are colonized with Candida, how do you interpret any of those molecular tests? And, you know, there are all those labs that we know about that do molecular tests and find things that we never really thought even existed in areas. And then patients come in with them. What do we do with this? And, you know, is molecular testing really a good thing?
You're hitting the nail on the head. And you're exactly right by asking that question. So let me state the following. When the average woman goes to a gynecologist or to a family practice or to an internist, internal medicine doctor, with vulvovaginal symptoms, they don't get point of care tests, or the doctors are not trained in point of care tests. It's not an IQ issue. They're busy, they don't have time, they don't know how to do the microscopy, etc. They've never invested the tests. Every few months in a CID, you'll see an article about the tragedy of women going to doctors today. Doctors don't do diagnostic tests. So me doing point of care tests and being a reasonably good microscopist, I stand in my soapbox at all gynecology meetings and I say, you've got to do microscopy. And you know what? I've been doing this for 20 years and it goes in one ear and out the other. It is a waste of my time and effort. And so all the people, the old fathers like me, we've given up. And we say, do the molecular tests, because at least you're going to get a diagnosis. You're going to get the organisms. You're going to get the right diagnosis. Most of the doctors practice what we call syndromic medicine. They're saying, why are you here, Mrs. Smith? I'm here because of my yeast infection. That's already planted the seed of the diagnosis. Two, they examine the patients. They don't do pH. They don't do microscopy. They just say, well, this is probably a yeast infection. Nobody dies from a yeast infection. And if you're wrong, you'll come back and we'll give you a treatment for a bacterial vaginosis. That's the common approach. That's the standard of care that's unacceptable. So actually, the so-called intelligentsia are now saying, do molecular tests. What we've done is we've opened up Pandora's box. Now they're doing these molecular tests. They're getting all these organisms they're not trained to deal with. They're not trained to deal with. And just because you find an organism doesn't mean it's causing the symptoms. So you can see Mrs. Smith can be colonized with Candida glabrata for months and years. She goes to her boyfriend and they decide to sit in a jacuzzi. And the jacuzzi in her boyfriend's house has just been thoroughly cleaned with chlorine and a variety of chemicals to make sure it's clean. Very nice. Some of the stuff comes off in the water. And what happens is Mrs. Smith or Miss Smith gets an acute contact dermatitis reaction to the chlorine or whatever chemicals. Happens, I promise you, once a week in my practice. She goes to see her doctor the next day. The doctor sends off a molecular swab and the result comes back Candida glabrata. That Candida glabrata has been there for months, for years. You haven't established causation because nobody's asked about the jacuzzi or anything else. Glabrata, they need to know, is not common. When a patient who comes to you, and I don't want to just throw figures around. When a patient goes to a gynecologist and said, look, I've got itching and irritation and burning, and I've just had a course of antibiotics or not, and he examines the patient, she's got redness and edema and an abnormal discharge, and he finds yeast on culture or on microscopy, the likelihood that the organism comes back Candida albicans, the likelihood that Candida albicans is causing her symptoms is greater than 90%. It's not 100%, because there may be another reason why she has her symptoms, but it's greater than 90%, and therefore the doctor is obliged to treat, because there's a very good chance the organism you've identified is actually causing the symptoms. Glabrata is low virulence, very low virulence. There are tens of thousands of women walking around at the moment. Every time I do a microscopy section, every time I do a clinic, like tomorrow morning, I'm going to see women. When I do the microscopy, I see, oh, this lady's colonized, and I bring in all the medical students and residents, and I show them the Candida glabrata under the microscope. And she's asymptomatic. When you find a woman who's got symptoms, she's got Candida glabrata, the likelihood the Candida glabrata are causing the symptoms is probably about 10 to 20%. It's not zero. The problem is, if you had an easy drug for Candida glabrata, inexpensive, then part of establishing whether it is causing the symptoms is to treat the glabrata, but we don't. Because you're going to fail with monostat, you're going to fail with terazole, you're going to fail with fluconazole, and you're even going to fail with the brexafem 80 to 90% of the time. So the doctor has to establish causation. Not so easy. But as an IV consultant, you get a wound infection post-operative that's, you identify 3 to 4 organisms, and you have to decide, do I have to treat all 4 organisms? Which of the organisms do I want to treat? This is part of our training.
I had one more quick question. Early on, you talked about dysbiosis and that sort of role in candidiasis. Thoughts on potential for microbiome restoration with probiotics, or any potential there for non-pharmaceutical interventions?
You're exactly right. You're on target today. The probiotics have been prescribed for women for ages, for decades. Any woman who gets a yeast infection or a couple of more yeast infections goes on to probiotics. Probiotics are not considered drugs. They're available over the counter. They are not standardized. They're commercially available in enormous amounts. Most of the probiotics that women take are oral. The studies that have been shown about oral probiotics, almost none of them end up in the vagina. They're not standardized. Most of them have got lactobacillus species that never even can survive in the vagina. There are very few products that are available topically that do stay in the vagina. And what is the first issue is that in bacterial vaginosis, you have a massive dysbiosis. You've got total depletion of your lactobacillus species. In Candida, you may have an increase in lactobacillus inners, but for the most part, you retain with your normal pH lactobacillus acidophilus and lactobacillus crispatus, etc., etc. So there are no good control studies showing that probiotics, vaginal or oral, are effective for recurrent Candida vaginitis. I wish they did. We really need better probiotics for BV, but because we just don't see the significant dysbiosis with Candida, the dysbiosis is all with BV, and it's massive.
Okay, I think we're out of time. So I want to thank Dr. Sobel for a great lecture. I want to thank you all for your thoughtful questions. And everyone have a great day, and we'll talk to you soon. Thank you.
Okay, my pleasure. I hope I didn't bore you on this.
Thank you.
Topic.
Thank you.